as most of the cases which will be given to you will be of cataract, let us discuss the management of cataract. Friends, always remember management means investigations as well as treatment. Investigations are also a part of management. So let me share the PowerPoint presentation with you to, I mean, help you understand better about the management part. So, what are the parts in management? First, we have to decide when we have diagnosed a patient of cataract, when should we operate? Friends, this is the decision that is most of the time left to the patient. So the decision is most of the times we have to leave that decision to the patient. I will explain you why. So there are various types of indications about cataract surgery. Is why we are going to operate cataract. The most important and obvious thing that we have to give vision to the patient. Cataract has caused visual impairment, and we have to restore the vision to the patient. So that's why we operate the cataract in 99.9% of patients. So this indication is called as visual indication. So there is no set criteria or no rigid criteria when to operate depending upon visual acuity. It depends upon patient to patient. Some patients, like pilots, will be very uncomfortable even if there is a small posterior subcapsular cataract and vision is 6 by 6. Whereas farmer may not have any difficulty even in vision of 624. So what is the So the decision is mostly left to the patient whenever we are operating the cataract for restoration of vision. What is the bookish explanation for that? Let us again share the PowerPoint presentation. So whenever patient's visual acuity is impaired to an extent that the patient or the person is not able to manage his day-to-day activities, we have to operate the patient for cataract surgery. That is called as visual indication. I hope it is clear with you. So visual impairment to an extent which affects the day-to-day which affects the day-to-day life of the patient, then only we have to operate. So that is called as visual indication. So that is the indication 99.9% of the patient. So what is medical indication? Medical indication means we are operating cataract for diagnosis and treatment of retinal diseases. I will give you an example of diabetic retinopathy. Patients has a diabetic retinopathy, and we need to manage that diabetic retinopathy by using laser treatment. But the laser will not penetrate the retina. The laser rays will not reach the retina if there is significant cataract. So in such situation, we have to first remove the cataract and then we have to perform laser. Sometimes we are not sure what posterior segment disorder is the patient is harboring because of hard or dense cataract. In that situation, we just remove the cataract and examine the retina. So that is this indication is called as medical indication. Cosmetic indication means patient has optic atrophy or some other disease of the eye which has made that eye totally blind. Means we are just removing the cataract for cosmetic reason. Patient is bothered by white opacity in the eye, so that is called as cosmetic indication. Sometimes the cataract causes complications such as lens-induced glaucoma or uveitis, and in such situations also we need to remove the cataract because removal of cataract will lead to treatment will treat these conditions. So that is also an indication. So these are the types of indications of cataract surgery. So whenever we have decided that we are going to operate a patient for cataract, then what should we do? We have to do local investigations and we have to do systemic examination. So let us start with a complete comprehensive eye examination. We use the instrument called as slit lamp to assess the anterior segment. Anterior segment means the part of the eye which is in front of the lens, including the lens. So we can assess the cornea because corneal assessment is very required. If the cornea is hazy, then the patient may not get good vision after surgery, and his hazy cornea may become more hazy because during cataract surgery the endothelial cells are damaged. So that's why we have to assess the cornea and we have to give prognosis to the patient. So such patients, हम ऐसे पेशेंट्स को ऑपरेट करेंगे क्या? हम जरूर करेंगे, but we'll tell the patient that you are having this corneal problem, so that your visual recovery may be guarded, and you may have to undergo secondary or subsequent penetrating keratoplasty also. So that we have to assess cornea. Then we have to assess the lens grade. How hard is the cataract? What's the grade of the nuclear sclerosis? There are four grades of nuclear sclerosis. The grading is normally we assess the grade with the help of a chart that is called as LOCS grading. This LOCS chart has got photographs of various grades of lens hardness, which we stick where at the just adjacent to the slit lamp. So we see the patient on slit lamp and we compare the lens color of the patient with the LOCS chart and we grade the patient. It's that easy. So that's how we assess the lens grade. Then we can also assess the anterior chamber depth, because anterior chamber, if it is shallow, then there is a chance of raised intraocular pressure during surgery, or the manipulation of instruments may become difficult. And in excessively deep anterior chambers also, the surgery is difficult. So that's why we have to assess the anterior chamber depth. So these all things are called as anterior segment. So the first thing I am going to do is I am going to assess the anterior segment with the help of slit lamp. Then we have to examine the retina. So retina can be examined by, see, if we want to examine the central part of retina, that is optic disc and macula, we can use either direct ophthalmoscope or we can use 90 diopter lens on the slit lamp. And indirect ophthalmoscopy will help us to see the peripheral part of retina very well. Just I am pausing for a second. So we can examine the peripheral retina with the indirect ophthalmoscope. And in hard cataracts, in the dense cataracts, when we are not able to see with direct ophthalmoscope, even disc and macula can be examined by indirect ophthalmoscope because the indirect ophthalmoscopy light is bright. So we have done anterior segment examination and we have done fundus examination. So now these next two columns are very important. That is macular function test and retinal function test. So why we want to do this test? We want to assess where how much vision patient will get after cataract surgery, because when the patient is coming to you, डॉक्टर साहब मुझे ऑपरेशन के बाद कितना दिखेगा, so the ultimate visual recovery even if everything goes uneventful. So we have done a nice surgery, uh, we have implanted best lens in proper position, still the recovery will depend upon the how healthy the macula is, that is the central part of retina is, and how healthy is retina. So that's why we have to do macular function test. Visual acuity is a very simple form of macular function test, and that we have already done when we have examined the patient. And but in cataract patients, the visual acuity will be very less. Okay, so that's why we need to do these tests. And we have also tried to examine the fundus, that is retina, with the help of direct and indirect ophthalmoscopy. But in hard cataracts or in dense cataracts or in mature cataracts, we are not able to see the macula and retina clearly. So that's why these macular function tests and retinal function tests are important. So how do we perform these tests? So let us first discuss about macular function test. So macula is the central part of retina that is responsible for the central vision or visual acuity, what we routinely examine the OPDs. So macula is very, very important. So how do we test macular function? There are these three tests that we can use. That is, one is called as Maddox rod, then second is 2-point discrimination test, and third is red green perception test. So I would describe these tests little bit in detail subsequently. So what is Maddox rod? Basically, there is a lens in the trial film. a red colored lens which is made up of a cylinder. So that lens is called as Maddox rod. So what we do is we close one eye of the patient and we hold the Maddox rod in front of the other eye, right, like this, and we ask the patient to look at a far away point source of light. So what does Maddox rod do? Maddox rod converts that point source of light into a line. So normally, if the macula is normal, the patient will report that he's seeing a straight line. But if the macula has some problem, then the line will be either broken or the line will be wavy. So that is first step. That is called as Maddox rod test. So always remember, Maddox rod is also used for testing of strabismus, that is squint. But in that situation, both eyes are open. But when we are testing with for macula, one eye is closed and we hold the Maddox rod like this and we ask the patient to look at a far away point source of light. So this points of source of light is get converted into a line. So that is called as Maddox rod. Then second test is called as red green perception test. That is also very easy test that we can do routinely. There are red color glasses and green color glasses in our trial film. They are called as red and green filters. So what we do is we again we close one eye, put red filter in front of one eye, and ask the patient to look at again a light. So so the patient will say that मुझे red दिख रहा है. And when we are changing that red filter to the green filter, patient will say मुझे green दिख रहा है. So patient is able to differentiate between red and green colors. So this color vision is a test of macula. So this is called as red green perception test. So this Maddox rod test and red green perception test are done. I hope you are clear with this test. Then the next test is called a 2-point discrimination. This is also a very interesting test where what we have to do is we make a opaque disc, which we can make ourselves also. Take a cardboard and perforate it with two pinholes, and these holes are 2 inches apart, right? So एक कार्डबोर्ड लेना है, उसमें दो होल मारने हैं. The approximate size of the hole is 2 millimeter, and these two holes should be 2 inches apart, and we should hold these two hole two feet away from the eye, and we ask the patient to look through that opaque disc or the cardboard towards a light. So if the patient is able to perceive two lights, then it indicates normal macular function test. So this is a rule of two. I will again repeat. The patient is asked to look through an opaque disc perforated with two pinholes behind which a light is held, and the holes are 2 inches apart and held at 2 feet away from the eye. I hope you are clear. So what are retinal function tests? Macula is a small part of retina, but retina is big. Retina is what I mean superior periphery, superior retina, superior part, inferior part, nasal part, temporal part. So we have to see whether retina is functioning normally or not. Because in some patients may harbor retinal detachments, and patient will come to you with cataract also. But in such patients, we are not able to make out whether retina is normal, and we go ahead and operate the patient, and after surgery, patient will not get vision. So that is why retinal function tests are important. So projection of rays is a very simple test which we can perform routinely in our OPDs in patients with cataract. So how to perform this test? Basically, I'm trying to demonstrate to here on the video. So what I'm suppose I'm a patient. So I'm closing one eye. So patient is asked to close one eye, and torch, the examiner shines torch. Let us assume that this hand carries a pen torch. So light is flashed from various quadrants, like this is temporal quadrant, this is superior, this is inferior, and this is nasal. I hope I'm trying to just simulate. So light is shine from various quadrants. Remember, this test should be done in dark room, and we have to use a point source of light. So once I am shining the light, तो मैंने ऐसे यहाँ इस आँख पे हाथ रखा और लाइट ऐसे शाइन किया टेम्पोरल साइड से. तो मुझे पेशेंट को क्या पूछना है? What I should ask to the patient? So this is very important. I don't Please don't ask to the patient whether you are able to see the light or not. Patient को ये नहीं पूछना है कि आपको light दिख रहा है या नहीं दिख रहा है. That becomes perception of light. So what we have to ask to the patient is from which direction the light is coming from. लाइट किस डायरेक्शन से आ रहा है, तो पेशेंट विल से कि हाँ लाइट से आ रहा है, देन लाइट ऊपर से आ रहा है, लाइट नीचे से आ रहा है, लाइट लेफ्ट साइड से आ रहा है. सो this is a normal projection of rays test, or this is also called as accurate projection of rays. So how do you say किसी भी टेस्ट के बारे में क्या बोलना है, मतलब positive and negative, that's the word that we commonly use, but here what we have to use is projection of rays accurate or inaccurate. So I hope we have I hope it is I'm making it very clear to you how to check projection of rays. So we have to ask the direction from which the light is coming. So why is it important? Suppose patient's nasal periphery is gone and I'm shining the light like this, and this light is falling on the nasal part of retina. So if the nasal periphery is detached, then the projection will be inaccurate in that patient, in that quadrant of retina. So what does projection of rays indicate? So if projection of rays is abnormal, it indicates, or inaccurate, it indicates a serious retinal disorder like big retinal detachment in that quadrant. So inaccurate projection of rays is very, very important and significant, because then always the prognosis is guarded. So if the projection of rays is accurate, still the patient may have small retinal abnormalities which we cannot test by this test alone. But still, there is no big retinal detachment in that, or no big retinal problem in that patient. These are the conclusions that we can take from this projection of rays test. So this is very, very important, especially in patients with mature cataract. Still, if you are having doubt about retinal function, then you can perform ultrasonography. Ultrasonography B scan will tell us about the anatomy of the retina. Okay, so it also can speak about vitreous hemorrhage or retinal detachment or posterior vitreous detachment, etc. So this is we are proceeding with the workup of cataract patient. Yeah. So then what then what should we do? We should always check intraocular pressure. So why do we want to check intraocular pressure? Because if the intraocular pressure is raised and if we operate that patient, then the patient may have some complications like expulsive hemorrhage or posterior capsular rent because of vitreous thirst. So intraocular pressure has to be always controlled before cataract surgery. And second thing is that cataract and glaucoma may frequently coexist because both are the diseases of old age. So patient may have glaucoma also in addition with cataract. So then his visual recovery or prognosis may be compromised or guarded. So that's why we have to record the intraocular pressure. So how do we record intraocular pressure? There are various ways like digital tonometry or applanation tonometry or Shaw's tonometry. So which is the best? The best is applanation tonometry. What is the normal range of intraocular pressure? It is 11 to 21 or 10 to 21. Always remember, books have given different values, but different lower values, but the upper value is usually same, that is 21. So anything above 21 is, we can safely consider it as abnormal or high. So that is how you record the intraocular pressure. Again, I will try to demonstrate you how to do digital tonometry. So what we have to do is we have to rest uh, we have to rest our fingers on the forehead, and we have to ask the patient to look down. And I'm just placing here at the upper border of the tarsal plate with one finger, and other finger I'm trying to see whether I'm trying to judge the pulsation. So this is how we can record the intraocular pressure digitally. But this is a very crude test and it gives only rough idea. Means if the pressure, we can know whether the pressure is very high or very low with this method. But sometimes this method has to be used. Suppose the patient has got infection in the eye and we don't want to touch the cornea, then maybe we can use this test. So that is how you check the intraocular pressure. Then this regurgitation test. This regurgitation test is also very important because if there is blockage of the sac, then if we perform cataract surgery, because if there is blockage of sac, then there is a potential space where germs can reside. And if we perform cataract surgery in such patients, then these germs may reach the eye and they may cause post-operative infection. So that's why we have to do, always we have to check for the regurgitation test. So how do you perform the regurgitation test? Just see here. This is the landmark of lacrimal sac, that medial to medial canthus. Medial canthus means the part where upper and lower eyelid meet medially. So that is called as medial canthus. So we have to just press below and medial to the medial canthus with one finger and gently evert, evert the lower eyelid, retract the lower eyelid with the other finger so that we can visualize the punctum. So when we press and if something comes out of that lower punctum, that means that there is a blockage of the lacrimal sac and regurgitation test is positive. So this is how you perform regurgitation test. Sometimes the regurgitation test is negative, but the patient says that कि मुझे आँख से पानी आता है continuously. So we suspect that there may be some block. So then we can do sac syringing to confirm the findings of the regurgitation test. But the sac syringing is not done in all patients posted for cataract surgery. Recent protocol mandates that we should perform regurgitation test, and if we suspect block, then maybe we can go ahead with the sac syringing. So these were the local tests that we have performed in patients. Now, what are the systemic investigations? So systemic investigations are for anesthesia fitness, like chest X-ray, then ECG. These things are done to rule out any systemic disorders because we are giving local anesthesia to the patient. Then we have to do CBC, that is complete blood cell count or urine examination to rule out focus of infection. Okay. But the most important systemic investigation would be blood sugar because we always have to rule out diabetes before taking the patient for cataract surgery. Because last time also I told you that diabetes affects the wound healing and diabetes, uncontrolled diabetes can cause infection in the eye. So we never operate when diabetes is, when the patient has got uncontrolled diabetes. So to check the diabetes, we have to check blood sugar. So we are checking blood sugar and we are checking the blood pressure also because if the blood pressure is high, then there is a risk of anesthetic complication. And blood pressure also, if high blood pressure also can cause hemorrhage inside the eye when we are operating. So that's why we have to rule out blood pressure. That is, we have to rule out hypertension and we have to control the diabetes. We have to diagnose the diabetes. If the patient has already has got diabetes, then we have to control the diabetes or we have to diagnose the diabetes. Sometimes in India, patients may come to you directly without any history of diabetes and they will we found we find a very high blood sugar in them. So that is why this blood sugar is important. We have done everything. We have checked, we have taken anesthesia fitness, we have done local and systemic investigation. Then what next? The next is biometry. We are always putting intraocular lens in the eye. So we want to know the power of the intraocular lens. To know the power of intraocular lens, we have to do A scan. This A scan will tell us about axial length of the eye, anterior chamber of the eye, anterior chamber depth of the eye, lens thickness. These are the parameters that that are important for the intraocular lens power calculation. So we have to do A scan. This is ultrasonography A scan or UHG A scan. Then keratometry is done to measure the corneal curvature. And we put these two readings into a formula called as SRK formula, which gives us the approximate power of the intraocular lens that we need to implant. And we need to be ready with that power when we are taking the patient for surgery. Yes. So, friends, this is all about today's topic, that was investigations in patients with cataract surgery. So in the next class, maybe we will discuss about the various types of cataract surgeries and so on. So if you have any doubt, please free to contact me. If you want to give me any feedback about how to improve my presentation or if you are not able to understand any topics, please don't hesitate to contact me. Thank you so much for your time.